World Health Organization says natural menopause occurs after 12 months without menstruation that is not accounted for by abnormal physiology or pathology.
Welcome to Fempower Health. This is Georgie. Today we have the incredible Dr. Jerilynn Prior, a renowned endocrinologist with over 40 years of experience in women's health. And she is one of my listeners' favorite guests. And so I'm so happy to have her back. I believe this is our fourth interview. And by way of quick background, she and I catch up time to time. And I asked her to come on the podcast again. And she said, we need to talk about the difference between perimenopause and menopause because everyone is just saying menopause, but they are different and the treatments are different. So that's what we're doing today. We are diving in to why it's essential to differentiate between these two phases of life to ensure that you all are receiving the proper care and support needed during these transformative stages of life. And I will say, get your seatbelts on. I know whenever I interview Dr. Pryor, I put my seatbelt on because I know she does not mess around. She talks about the data. She has done so many trials, has worked with so many women, really does her research, and it's always a pleasure to have her on. So get your seatbelts on and enjoy this awesome episode. Dr. Pryor, so many people know you from having listened to the podcast, but for anyone who's new to the Fempower Health community, can you just do a quick introduction and then we're just going to dive right in?
I'm professor of endocrinology at the University of British Columbia with 40 years of women's health research under my belt. And in that time, I've learned some remarkable and very important things that the medical world in general is resistant to knowing. Therefore, I believe women need to know it and need to demand it of their physicians.
Absolutely, absolutely. Perimenopause versus menopause. I 100% agree. We need to differentiate. And incidentally, I think the world just works perfectly in timing because I've gotten such interesting questions from friends and people in the Fempower Health community. So I'll be sure to trickle them in throughout this discussion. But first, talk to us about why it's driving you so crazy that we're using this overarching term menopause, whereas we need to really differentiate.
Okay, it's a long story, but we'll start with this. Perimenopausal women are still menstruating. They have very high and erratic estradiol levels, and it differs in the quality of the hot flushes and night sweats and the proportion of the two, and the therapy is different. So, all of those reasons mean that we must differentiate between these two if we're going to, one, deliver proper care, and two, be accurate scientists.
Yep. No, absolutely. And didn't you say something about why, something to the effect, and you have a great quote, so I hope you remember the exact quote around endocrinologists versus OBGYNs and who should be managing hormone health. Would you like to address that?
Here's what I would say. When you think about it rationally,
Hmm.
those who should be the experts in women's reproductive health, which we know is strongly influenced by the social, environmental, genetic, ethnic diversity of people, should be those who are trained in those areas and are not simply pelvic surgeons.
Yep. Having done this podcast for over 4 years and interviewing well over 100 experts, I do have this like fascination because I also have a consulting background and all my stuff is around process. And so my brain is like, I feel like the whole healthcare system and who's doing what is just off. And I think this is a great example of one of the things that hopefully we can fix down the road. So
Well, it's a systemic issue.
yeah.
It's a cultural issue. The gynecologic community has a departmental role in every medical school in the United States and Canada and around the world. And therefore, they have a power that they don't want to lose.
Right.
And I'm not saying for a second that we don't need pelvic surgeons, but I wouldn't do a hysterectomy. I know better. I don't know enough to do one safely. But there seems to be lack of insight into what they do know.
Well, and we know for menopause, like, I mean, even only 30% of medical schools, based on recent data, even teach it. So, lot of things to catch up on. So, let's get into perimenopause. Talk to us about these symptoms and how we need to look at symptom management differently.
Okay, first of all, let's start with definitions.
Go for it.
What does menopause mean? The World Health Organization says natural menopause occurs after 12 months without menstruation that is not accounted for by abnormal physiology or pathology. Period. Full stop. Okay. What do gynecologists call menopause? The official documentation in gynecologic literature of menopause is the final menstrual period. Well, how do you know that's final? So that's a retrospective diagnosis. And some doctors will say, oh, you've been 2 months without a period, you're menopausal.
Ah,
Seriously.
okay.
Okay. So that's where the word postmenopause comes from, which is the official language of the FDA. But in my book, if menopause begins after 12 months without flow, we don't change our status as menopausal women throughout the rest of our lives. So postmenopause means
Menopause.
dead. Postmenopause means dead. Well, I mean, okay. Now, what does the average woman on the in the community call menopause?
Wow, that's a really good question because here's what I will say I am seeing is I have friends, I even spoke to one this morning who is now saying, "I'm starting to have trouble concentrating and thinking and making decisions." I'm like, "I think you're in perimenopause." I hear so much resistance about that term and people not wanting to accept it.
She's entering a new phase of her life,
Yep.
and she's not ready to accept that yet, because we associate menopause with being wrinkly and decrepit and demented and old and all the undesirable things in our society. And that is absolutely not the case. Perimenopause often can begin as young as 35, which is very young,
Hmm.
right? So perimenopause is not old.
Right.
However, the average woman, when they see anything negative happening from midlife onward, call it menopause. In other words, the average person equates perimenopause and menopause, making no distinction. The first big problem about the differentiation of perimenopause and menopause is the definition of menopause.
Yeah.
And we need to fix that.
Yep.
Now, first of all, where does that definition come from? It comes from an early study that started with undergraduate women in some college in the middle of the United States in the 30s, if you can believe it.
Okay.
Loire was the guy who he began that study. And basically, when women had reached 45, if they'd been 12 months without another flow, then 90% of the time they were not going to get a further flow. However, 10% of the time they were. Now, if they were younger than 45 after 12 months without flow, they had a 20% chance, two out of 10 chance of having a further flow. And let's talk about that right now, because when you have flow after you are in menopause, that's endometrial cancer until proven otherwise. However, the definition of endometrial cancer predicting flow is asymptomatic. You had no clue it was coming. So if anyone has 12 months without flow and then gets another period, ask yourself, did I feel any different before this started?
Right.
And if it is one of those 10% or 20%, you will say, oh God, yeah, I remember now. My breasts were sore. I felt crampy. I felt bloated. If you feel those PMS like symptoms, that is a normal further flow. And you start the menopause clock again, the 1 year. If you didn't have any of those symptoms, you go to see a gynecologist right away for an endometrial biopsy.
Women need to be tracking, and right now I would say with all the startups that are out there, there's been so much awareness created around tracking your cycles, but a lot of that has to do with trying to get pregnant. And I'm not
Mhm.
sure how much awareness there is around tracking your cycle, from your late 30s onwards or mid 30s onwards, because I was quite aware. I was tracking and I knew. I was like, well, if I don't get my period by Thanksgiving, I've hit menopause, and I did. And yeah,
Congratulations.
so, it's really
I
important.
consider it graduation
There you go.
because I had such a difficult perimenopause.
Did you?
I'm just before the traditional baby boomers,
Okay.
and so there was no information. And I said to myself, "Look, I know bloody well that, pardon me, but that sore breasts are not caused by low estrogen.
Right,
This cannot be low estrogen because I had sore breasts for 10
right.
years." And I tried and tried and tried and proved that estrogen levels are higher in perimenopause than they are in premenopausal women, the sexiest 20-year-old.
Well, so talk to us about these hormone changes and what's really happening in perimenopause. Because one of the things that I've been thinking a lot about since we discussed covering this today is how do we do the treatment? Because there's so much in the press and on social media around hormone therapy. But as you alluded to very early on, it seems to be much more for women in menopause, or as some are knowing it as postmenopause. So, what happens in perimenopause? So let's dive into that.
I think it's helpful to know why something happens. Okay, so we have several million follicles. That's a little circle of cells with an egg inside within our ovaries when we're born. So each cycle from our teen years, from our first period onward, there are half a dozen follicles that get stimulated, and one becomes dominant and may or may not release an egg. Okay, so even at that rate, we don't use up all of the follicles that are in our ovaries. The evidence shows that from the late 30s onward, there's a rapid increase and decline in the number of follicles in ovaries. This has been shown anatomically, it's been shown with ultrasounds, etc. Okay, so why is there a sudden increase in in the number of follicles that are stimulated and that get absorbed from the mid 30s or late 30s? And the reason is that those older follicles that were closer to the center of the ovary, because the follicles gradually move outwards and it's the farthest outwards one that are ready to ovulate.
Okay.
So those center of the ovary follicles are making less of a funny little hormone called inhibin. Now, inhibin's job is to talk back to the pituitary FSH, follicle stimulating hormone, and along with estrogen to suppress it. Well, if you don't have enough inhibin, estrogen alone is not reliably going to suppress FSH, so more follicles get stimulated, right? More of them make some estrogen. Estrogen levels become unpredictable and high, and get rid of more follicles, but at the price of higher estrogen levels. So that's the major change. Consequent to those changes are changes in two other hormonal systems. One is that although we may continue to ovulate, we don't make as much progesterone. This discoordination at the hypothalamic pituitary level means that we can't get it together to ovulate as frequently. And when we do, there's less progesterone made. That's not clear why, but that's what we know. And the other thing that happens is that with estrogen being super high, it also comes down fast. And that's considered by our body as an emergency. It's like a drop in blood sugar.
Okay.
It triggers a a great brain stress response. So every hormone we know how to measure increases. And that downswing in estrogen, I call it when estrogen takes a dive,
Hmm.
is associated with depression, hot flushes and night sweats, increased bone resorption, and many of the stress related symptoms that we have in perimenopause.
Okay.
So those are the three changes: higher estrogen, lower progesterone, and higher stress hormone levels in perimenopause.
Because there's so many fluctuations, what can be done to manage these symptoms? Because it's really like perimenopause for me, from a mental health perspective,
Hmm.
was a nightmare. To me, what I'm thinking we need is stability. So, what is it that we do? Because right now, clinicians are prescribing a lot of mental health medications.
Progesterone covers that. It really does. For many reasons, partly because there were some very early studies that showed that medroxyprogesterone improved night sweats and hot flushes.
Okay.
I became aware that this was an important potential therapy for perimenopausal symptoms.
Right.
And Estrogen Storm Season, that I originally published, this is a novel about 8 different women having different life experiences and trouble in perimenopause.
Right.
Um, in that novel, said I presented use of cyclic progesterone. And it was not that long after we had the natural progesterone in those days. But um, we now know from a randomized, double blind, placebo controlled trial, we had almost 200 women. It turned out to be very difficult to recruit women to come into a research center, but we made all of our tools online so people could participate remotely.
Okay.
Therefore, we did a trial that was with women from across Canada.
Wow.
I say from Nunavut in the far north to Nanaimo in British Columbia.
Right.
And half of the women were on something that looked identical to progesterone but had no hormonal effect, and half were on active progesterone.
Okay.
And what we found, first of all, I have to say this, is that we did not have power with almost 200 women to show a difference between the two therapies. And why is that? Because at the baseline, our vasomotor symptom score had a variability that was almost as big as its value, which is huge. And so the variability makes it difficult to show a difference in a randomized control trial, but no one had tried to do such a trial before. So we had no guidance.
Right.
And we long ran out of funds.
Right.
So we had to beg and borrow to do another year of recruitment. The primary outcome was overall vasomotor symptoms, night and day, both on the third month of 3 months of therapy compared to 1 month in which women were not treated.
Right.
They just recorded their symptoms. However, when you do that, there's a variation around that result. And the variation around that result included a value that was clearly important.
Okay.
In other words, we couldn't exclude a benefit, but we couldn't prove it either. Okay. However, we had secondary outcomes in that trial, and the trialists are very religious about these things.
Hmm.
The secondary outcome was women's perceived change in night sweats, hot flushes, sleep, and flow,
Okay.
menstrual cycles.
Okay.
So women perceived a highly significant difference in night sweats. Women perceived a highly significant improvement in sleep. Women didn't perceive a difference in flow, which is interesting. In other words, this says that inhibin lack of feedback is sufficient that even full dose progesterone every day didn't suppress flow for most women. which is a useful thing to know.
Yeah.
Okay. And what we further found out is that we did, at the request of one of the people on the Data Safety Monitoring Board, we did include at baseline a questionnaire about depression
Okay.
because they were concerned that we might enroll women with depression and they might get worse and blah blah blah,
Right.
etc. So I said, okay, if you make us do it at the beginning, we'll do it at the end.
Okay.
And we did.
Okay.
And it showed no worsening of a depression. In fact, it tended to be better, but it wasn't significant. Okay, but the final thing that we did, and this is a tool that we'd used in a community study in Victoria, which is some distance from here, which was 10 centimeter line. Women, divided into 10 parts, and women would draw a vertical line across from no interference to extreme interference of perimenopause with their daily life.
Okay.
And we had one of those for mental emotional interference and another for physical. And that showed progesterone decreased the interference of perimenopause with daily life by 40%.
And can you share the dose? Because I know that was one thing we discussed.
This is very important. Progesterone has this positive, I mean, its major side effect is something that's very valuable, which is that it improves deep sleep.
Right.
Okay, so therefore, you only can take it at bedtime or just before you're going to sleep for your major sleep of the day.
Hmm.
Okay, so the dose to keep the blood level in the luteal phase range needs to be 300 milligrams of oral micronized progesterone. And that's what we gave in this trial.
Okay. So the conclusion I'm hearing is progesterone improves the experience and the ideal dose is 300.
That's correct.
Okay.
More specifically, it improves night sweats. We can prove that.
Okay.
Whether it improves daytime flushes, we can't quite prove,
Okay.
but the likelihood is it does.
Okay. There is so much discussion on social media around estrogen. And I just want to make sure that we're really clear on phases of life and what treatments work when.
Okay, may I
Please.
also interject here? Earlier,
Hmm.
published in 2012, we did a randomized controlled trial with 132, I think, menopausal women and showed that progesterone was effective for vasomotor symptoms, both hot flushes and night sweats, and for improving sleep in menopausal women. And my feeling is, and my choice would have been if I needed it, um, to use progesterone rather than estrogen, and only if there was another reason for also using estrogen to add it.
And what would be the other reason to need estrogen then?
I guess if you had low bone density already
Okay.
and you were worried about osteoporosis and you were close to, you were at a younger age and you didn't want to take the standard osteoporosis medicines, estrogen decreases bone resorption, progesterone increases bone formation. So they work beautifully together on bone.
Interesting. This is going to be an unpopular statement. So I'm scared to say it. And I don't know if you've read her book yet. Dr. Lisa Mosconi wrote a book that she just published called, I think it's called The Menopause Brain. I haven't read it yet, but I did speak to someone who did, that it was all about estrogen and no
hmm
or little discussion about progesterone.
hmm That's typical of neuroendocrine
Got it.
research today.
Okay.
They basically assume that estrogen is the only neuroactive reproductive hormone, and that's exactly wrong.
Yeah.
I mean, we know that progesterone works in the brain, or it wouldn't raise the core temperature, and it also wouldn't help night sweats and hot flushes if it didn't work in the brain.
And it's funny. Like I mean, you and I have spoken. We actually did an episode on progesterone versus estrogen, and I know that was incredibly popular for quite a long time when it first came out. And I feel like we still have such a long way to go with progesterone and understanding it. So I want to ask you this
hmm
next question. So I'm going to ask the whole thing before you
hmm
respond. Okay. So I was talking to a friend and she's in perimenopause. And she was put on, I believe it was hormonal birth control. And so we started talking, and we started asking each other some interesting questions that I hadn't really thought about, and maybe they're dumb questions, I don't know, but I'm not afraid to ask any question because it's important to get the right answer. So I'll just ask, and you can laugh at me. That's okay. So, um, one, if you're on, so one we're going to discuss, is that the right treatment? Obviously, you're going to respond to that. But the other is nuances, because one of the things we have discussed in the past and I've discussed with many experts is you always want to know what's happening to your body. Ovulation is a sign of reproductive health. It's a sign of what can happen in perimenopause and menopause. And if you're taking hormonal birth control, it kind of messes things up. And so if you're on birth control, how will you ever know if you've hit menopause? And then at the end of the day, does it matter? And two, she asked a really interesting question, which, does birth control impact the timing of menopause?
So, by definition, someone who is in perimenopause at a normal age
Mhm.
is usually in their late 40s. And until I mean, in Canada, I think it still is that you should not be prescribed birth control pills if you're over 35, and especially if you're over 35 and have one of two um, other things. One is
Okay.
smoking, and the other
Okay.
is obesity. Both of those things increase the risk for blood clots. And the birth control, the combined hormonal contraception, which is the right way to say it, because it's available as a patch and as a vaginal ring, as well as orally, increases the risk for blood clots. And it increases the risk for blood clots more as you get older because clotting risk increases as we get older.
Okay.
Okay. So, as far as I'm concerned, it's absolutely contraindicated to take the birth control pill in perimenopause. However, also, we know from a randomized controlled trial with about 130 women that was done with the 20 microgram ethinyl estradiol pill published in 97. It was a trans Canada study, and there were 77 women who had hot flushes. It didn't improve them significantly compared to placebo.
Okay.
Health related quality of life was not improved overall in that study. And in the first 3 cycles, it made bleeding worse. They started having mid cycle spotting and other kinds of bleeding problems. Okay, the bleeding did get better by 6 months, however, but most
Okay.
women are not going to put up with stuff like that. So we have good data that it doesn't work in perimenopause for vasomotor symptoms or for improving quality of life.
Well, her response was, I like that I know when I'm getting my period. I don't like that it's unpredictable and I'm constantly having to carry all these things with me because I never know when I'm getting it, because this is when our menstrual cycles change and it's not the, you know,
Mhm.
typical cycle that we've had since adolescence. So what would you say to women who are like, you know what?
Well, I mean that's like saying I don't like fall or I don't like winter. This is part of a normal part of life. Suck it
Mhm.
up, you know? No, grow up and accept reality.
Okay.
Okay. However, just not, no, I'm being facetious, but obviously her what she wants is what she likes matters.
Yes.
But the the Mirena or the levonorgestrel releasing IUD does have some control over cycles in perimenopause, does provide contraception. However, it doesn't control hot flushes and night sweats, and there are some concerns about it, like related to breast cancer.
Okay. Could someone theoretically take the IUD and then 300 milligrams progesterone?
Of course,
So now the next one is progestin. Can we talk about that, please?
it is unconscionable that a synthetic knockoff is ever called progesterone because there is only one progesterone. It's the molecule that our ovaries make normally.
Hmm.
And that molecule now is available as a therapy, thankfully. But but often the scientific literature, especially gynecologic literature, will say progesterone does such and such, and what they studied was medroxyprogesterone or some other progestin. And that's just not okay. The reason that's important is because we can know how progesterone works in tissues. Most the most times we don't know how progestins work in different tissues. We only know how they work in the vagina.
When we last spoke, we talked about vaginal estrogen. I do want to talk about the tablet versus the cream.
The perception of vaginal dryness or a feeling of discomfort with sex. In spite of what I said about high estrogens in perimenopause, occurs for a huge percentage of women who are perimenopausal
Okay.
and whose estradiol are probably flying about. And that occurs because I think, and this I can't prove this, that women in perimenopause are too distracted by all the things that are changing to have the focus necessary to enjoy sex most of the time. And therefore they avoid it
Okay.
or are passive about it. And if you if you're passive about it, your tissues don't moisturize themselves and
Okay.
therefore it feels it doesn't feel good. That is not going to be treated by estrogen, topical or otherwise, because it's occurring at a time when systemic estrogens are high on average. So now let's come back to your question about tablet versus cream. The safest treatment for vaginal dryness or dyspareunia, pain with intercourse, when you are menopausal now, without a menstrual period for 12 months or more,
Hmm.
is estriol
Hmm.
in a very low dose once a week. It takes extremely small amounts of estrogen to make the vaginal tissues adequately responsive and thick, etc.
Okay.
It is an extremely sensitive tissue to estrogen.
And this is the cream.
This is a cream, but currently, as far as I know, it has to be compounded by a compounding pharmacy, and I know that's sort of anathema to people in the US. It
Yes.
needs to be prescribed here in Canada. It
Okay.
should be prescribed wherever it is given to women. Although the tablet has a very low dose of estrogen, you're putting it way up at the cervix. It isn't the cervix that's dry. It's at the intersection of the vulva and the vagina that it's dry. So that's why it doesn't make sense to me, nor does it make sense to use one of those applicators that shoves it up inside. Put it on your finger, the amount like you would put on a toothpaste on a toothbrush, and rub it in the part of the vagina that you can touch.
It's interesting that you're bringing, and this is why I wanted to bring this up because I switched from the tablet to the cream based on our discussion. I got the applicator, right? And because I was taking the tablet, I was used to it going all the way in. And so I see this applicator and I'm like, and I don't think I'm supposed to put it all the way in. This doesn't really make sense based on where I was even having dryness. And so I wanted to ask. So thank you for verifying. So, ladies, let's get rid of those applicators. You can use your fingers. Measuring hormones. So, what's happening now is in this perimenopause phase, there are a lot of companies that were started as measuring hormones for fertility, and they're now expanding into
Mm.
measuring hormones during the perimenopause phase to create awareness because we all have agreed, everyone agrees measuring your hormones on a specific day doesn't really give a lot of information because in perimenopause, it's much more around symptom based management. However, these companies are there and it's measuring every day for however many days. I would love your thoughts around that.
All I can say is that as a practicing endocrinologist, and that was some years ago, I rarely, measured hormone levels. Here's something that I think is more helpful for women. I think learning learning the signs and symptoms of your own body are more important than asking a lab to tell you something that you can't really interpret
Okay.
and paying a lot of money for it. I know that there are people who think the more money you pay for something, the more valuable it is.
Hmm.
That, you know, that's not my approach. So here's one thing that's very helpful. If you put the palm of your hand over your nipple and push back toward your spine,
Okay.
if it's sore at all, your estrogen level is high. That is a pretty reliable sign. And in
Okay.
perimenopause, it's a very helpful sign. So I had sore breasts for 10 years. And many of those years I had regular cycles. So I didn't meet the criteria
Okay.
that's currently out there and is inappropriate for perimenopause. In other words, I don't think you have to have irregular periods if you have night sweats, if you have signs of high estrogen, if you have sleep problems, or the many other things that are common in perimenopause. Even if you have regular flow, you should call yourself perimenopausal.
Okay.
You can make that diagnosis yourself. And if you look on the SEMCOR, the Center for Menstrual Cycle and Ovulation Research website, which is what we run, it's now 22 years old, you will find an article called How Can I Tell I'm in Perimenopause? And it describes the 9 symptoms or experience changes that can tell you. One of them is that before cycles get irregular and longer, they get shorter. That's a very
Okay.
useful sign. Another is that cramps may come back. Another, and this is very common, is heavy flow. And it typically is blamed on fibroids. But where do fibroids grow? They grow in the
Yeah.
muscle of the
Okay.
uterus or on the outside. Only 10% of the time do they grow next to the endometrium where they could cause heavy flow.
Got it.
So
Okay.
perimenopause itself causes heavy flow.
Now, we are in this age where everyone's trying to measure everything. We've got the smart watches and whatnot. So
Mhm.
let me ask you this. If someone is like, I just like to measure, I feel like the measuring is almost helping create awareness. So, from a, I just want to know, is it helpful data?
It
Okay.
depends on what you measure. I mean, we have in the on the SEMCOR website, free also in the middle of the main page, menstrual daily perimenopause and daily menopause diary, 3 different
Okay.
diaries.
Okay.
Keeping the diary will tell you as much or more than a whole bunch of blood tests will or
Okay.
urine tests. And by the
Okay.
way, urine tests are not accurate
Okay.
for assessment of hormone levels.
Okay.
They are influenced by your ethnicity, for example. So if you're East Asian, Japanese, Korean, you're not as likely to have the higher estrogen levels in the urine, especially as you would have if you measured it in serum because of metabolism.
Okay. So then I guess because you brought this up, there were questions at ACOG around ethnicity and symptoms and symptom management. Do you have data on that? Because the doctors seemed to indicate that this we need more information.
The study of women across the nation did a good job of recruiting Black, Hispanic, Japanese, Chinese Americans. And they did show fewer hot flushes and night sweats in Japanese and Chinese Americans, significantly fewer. But also, those two populations were better educated than the average otherwise. And they also were less likely to. There was a question about how much does let's see, how did it go? Do you have difficulty paying for the basics? Fewer of Japanese and Chinese women would say they had any difficulty, and more of the Black and Hispanic women did have difficulty. And that, I think, another important concept is I already said that stress hormones were related to hot flushes. Well, they're absolutely fundamentally related because what happens is that when the brain norepinephrine, which is a big
Mhm.
stress hormone, is elevated, it narrows the temperature at which we feel comfortable. So we're more likely to shiver and more likely to sweat. Okay, we have no temperature resilience. So those people who are stressed by their environment, their work, their kids, their partner, their whatever, are going to have more symptoms in perimenopause. So what we need is to support women, help them to understand what's going on,
Yep.
listen when they're having a miserable day, not try to fix things because it isn't fixable in the short run, but always keep saying this will get better.
What about the role of melatonin? I didn't realize melatonin also changes.
Melatonin and progesterone are related.
Okay.
I don't know very much about it. It is an important physiologic hormone made by the pineal gland in the brain, and it does improve sleep.
I guess any final words for women in this phase of life, and how should we advocate for ourselves, with our families, and even at our doctor's office? Like what would be your words of wisdom?
Well, I think you need to go to your doctor with a clear understanding of what's bothering you most. In other words, ask for what you need. And if you're having night sweats that wake you twice a night or more, or twice a week or more, ask for progesterone and be very clear about why you need it and what dose you need.
Okay.
Because if you come with a whole bunch of symptoms, which are perfectly accurate in perimenopause, the doctor is likely to make a culturally biased assessment that you're a bit exaggerating, you're hysterical, you're histrionics, or, something weird like that. Say to your doctor, let's just do an experiment. Let me have 3 months supply. I'll keep my record and I'll come back and show you, and we'll know whether it's going to help me or not.
And then with respect to the mental health aspects, my fear, and again, every medication has a specific purpose. We may, feel some are better than others, but in this particular phase of life, I know that one of the bothersome things is the mental health aspect. Some may not even go to their doctor for the night sweats. They may not. And maybe it's the mental health aspects, and they may lead with that, which means they're going to be put on SSRIs.
Okay, so if they are having night sweats, they should mention them and not the depressed feelings or the other mood things, because
Okay.
doctors will not otherwise ask about
Hmm.
what's probably causing. And so,
Okay.
as I said, it's a great relief that we know from this randomized controlled trial that progesterone does not cause depression, because
Okay.
that's been sort of the implication in the literature for years.
I am so honored that you made time and that we've had such a great time together over the years. And this is such an important topic. And thank you for saying this is what we must discuss because it is important. And I appreciate just having fun with you about it, but also being really serious and data driven and just helping those who are struggling and learning how to advocate for themselves. So, truly, thank you for your commitment to women's health. It is an honor to know you.
You're very, very welcome. And I'm hoping that the investment that I've made in learning this information and in starting and supporting the Center for Menstrual Cycle and Ovulation Research will allow someone to step up and start supporting it when I'm retired and can't anymore.
It will continue. You're amazing. And so many people just talk about the gift that you've given all of us. And so, truly, thank you. And that wraps up another insightful session here on the Perimenopause and Menopause channel of the Fempower Health podcast. Before you go, I've got two quick, exciting invitations for you. First, join our vibrant community by subscribing to our newsletter. And it's not just any newsletter. It's your frontline update on groundbreaking women's health research, the latest health-enhancing products, and unique discoveries you won't want to miss. All of this delivered straight to your inbox, cutting through the noise of social media algorithms. Better yet, you can pick the Perimenopause and Menopause edition or the Chronic Pelvic Pain edition, or both. Second, if you enjoy our Perimenopause and Menopause content, don't forget that we also have a main Fempower Health podcast feed that covers a wider range of women's health topics. Additionally, if you're interested in chronic pelvic pain, you can subscribe to that specific feed too. Find these channels on our website or wherever you listen to podcasts. And if you love today's insights, show your support by rating and reviewing our podcast. Your feedback is more than just a pat on our backs. It lights the way for others seeking guidance and community in their health journey, amplifying the voices that need to be heard. And for a deep dive into today's topics, check out the show notes and explore our website at fempower-health.com. Our site is a treasure trove of knowledge neatly categorized by topics of interest, ensuring you find exactly what you need to empower your health journey. And your voice matters to us deeply. Whether you have a question, a story to share, or feedback on our episodes, reach out directly at info@fempower-health.com. Drop us a message on social media or hit reply on any newsletter. Your insights inspire our conversations. And don't forget to follow us on social media for more updates, tips, and community interactions. We're on Facebook, Instagram, and TikTok at fempowerhealth.perry.meno. Quick note, the knowledge we share here is to embolden you in discussions with your healthcare provider. It's not medical advice. Always consult with your doctor for health decisions. And remember, the diverse perspectives of our guests reflect their individual journeys, and it's not an endorsement by Fempower Health. And here's to empowering your health journey, one episode at a time. See you on the next Perimenopause and Menopause episode of the Fempower Health podcast.